Dr. Ayel Yahya. Dr. Ayel, he is adult hematology and stem cell transplant consultant at King Abdulaziz Medical City, Riyadh. Dr. Ayel will focus on, he is a focus on myeloproliferative neoplasm and clinical research. He will talk about what are the current common approach to treat CML. Dr. Ayel, floor is yours.
Salam.
Before Dr. Ayel starts, there are missing keys in the SSBMT bag. So if you find these keys, return them. Afwan, before Dr. Ayel starts, there are missing keys for someone who left it in the SSBMT bag. So if you find this bag or accidentally took it, please return it. There are keys for somebody here in the audience. Thank you.
Assalamu alaikum. Thank you for the invitation, and also I'm going to take the chance to thank the organizing committee for giving the MBN more attention. So probably this is the first session you have, like I think more than 3 or 4 talk about the MBN. So I'm going to covering the CML, and there is no disclosure to be discussed. So CML is a malignant clonal disorder of hematopoietic stem cell, is leading to increase the number of the mature cells, but they are dysfunctioning. The common age is between 40 and 60 years. However, in Saudi Arabia, we have younger patients with the CML. It is coming from the translocation between chromosomal 9 and 20, BCR-ABL, and end up with a gene called BCR-ABL, which increase the cell proliferation and decrease the apoptosis. So under normal condition, the autoregulation of the ABL occur when the myristoyl group at the N-terminal, which is the blue one here, of the ABL1 bind to the myristoyl binding pocket and make the ABL inactive. So all what we have now as a treatment for CML is focusing in the kinase domain, either as ATP competitive or that's one that can bind to the myristoyl pocket and preventing the mechanism of the CML. So once you diagnose CML, so CML is diagnosed either through the family medicine or even in the internal medicine. So usually they present asymptomatic, and they came with most likely lift shifting. And there are 3 phases, which is the chronic acceleration and the blast. Acceleration is not anymore in WHO, but still in ICC. And just show you here without treatment, like if patient diagnosed who have chronic phase, they have 5 to 6 years before progression to the acceleration, even without treatment. And we have like up to 9 months for acceleration to move to the blast. So this is a nice paper. It's showing us that the leukemia ranks as the 5th among the most frequent cancer in the Saudi Arabia. And the CML is more prominent, which is also interesting in younger patients in our population. We see those 19, 20, and above who have a CML. And it is more common in male and female around 44, and 7.2 is the mortality rate amongst the Saudi leukemia patients. So this for all leukemia, not only the CML. CML, it seems, is the most common between the leukemia patients in Saudi Arabia. So once you diagnose CML, then you need a prognostic score. We have 3 validated scores. The most common used these days is the last one, the European ELTS score, and SOCAR still used, but most of the old trial or study were using the SOCAR score. Why we need this score? This score is helping us also in the decision of the treatment or choosing the target therapy. So I'm just showing you the survival outcome before in the impact of the TKI era. So clearly this target therapy, the introduction of the targeted therapy radically altered disease progression. The cumulative incidence of blast crisis dropped dramatically for patient who start for the patient with the TKI when you compare with the old protocol, which is the chemo or combination with the interferon. And even those who's in the blast crisis, The survival, you can see the pre-imatinib and the post-imatinib. In the pre-imatinib, the median survival around 4 months. And in that study, around 700, the one on the right side, around more than 700 patients. Before the era of imatinib, around 600 died. And when you compare with the imatinib era, is around just 47 who died. So what about the survival with the era? The 5-year relative survival with the TKI era is around 94 patients. And even the life expectancy almost normalized for the CML patient. This is a data from the Swedish CML patient, and regardless of the age, regardless of the gender, the life expectancy climbed down since 1970 to reach almost the normal population with the TKI. So once you diagnose the CML, then you have to start the therapy. So what we have these number of target therapy. So we have imatinib as first generation that came at 2001. Then we had the second generation, dasatinib, nulatinib, and also the third generation bunatinib, which is used only the second line. And in 2021, we start to have asciminib approved as the third line. And in 2024, we have asciminib as first line also approved. This is the selectivity of these target therapy of the kinase. The more red spot is the more blocking of the conformation of the tyrosine kinase. The more red spot, the more result. I mean the good response, but more side effect. These are the drug available and all approved as first line at the moment, apart from the bunatinib. And we will go through them quickly. So we have the imatinib. Imatinib is still working drug, the first TKI approved. Is simply 1 tablet a day, taken as pill with food or without. So regarding the quality of life, not as much. Regarding the side effect, is mainly diarrhea, nausea, muscle pain, and usually the patient, if just continue for 1 month, this symptom will be much improved. So usually we ask patients just we support him during the first month until the body tolerate. I think fluid build-up is a concern, and clearly there is no cardiac toxicity with imatinib. So that's why most of us, we like imatinib. Dasatinib is predicted to bind to multiple conformation of the ABL kinase, and is overcome the resistance that noticed with the imatinib. The side effect, the simple side effect like imatinib, nausea, vomiting, muscle pain, and again, usually we ask patients to continue on it, and and we support them, and most of them they adapted. However, I think the build-up fluid is more common, mainly the pleural effusion with the dasatinib. Regarding cardiac toxicity is not that much with the dasatinib. And however, though I think this is not only the side effect. I have patient who's like young, 20 years old, and I have been following him for a year and a half. And at the beginning, he was just coming without wearing a cap. And then after 6 months, I noticing him wearing a cap. I ignored this in the second visit. Then I asked him why. Then he take the cap. He lost his hair. He has alopecia. I never asked him. I never counsel him for that. Definitely, there is more side effect, especially in our younger population. Nulatinib is another TKI. It has higher affinity. Again, is overriding the resistance developed with the imatinib. However, look how we use the nulatinib. So if you're gonna take nulatinib, is twice a day. You need to be fast 2 hours before, 1 hour after. So over the day, the patient need to fast for 6 hours. And I think this is going to impact the quality of life. However, it's a good drug for controlling the disease. The side effect, again, nausea, vomiting, the rash, it's happening, but it's tolerable. But the fluid build-up, it is still there, is less than dasatinib, but is there. And I think the other side effect is the cardiac toxicity. We see it with the nulatinib. Again, the electrolyte disturbance and the pancreatitis is a risk there. Bozatinib is another TKI. Just to point here, the bozatinib is not inhibit the domain mutation T315. And why I'm mentioning that, because asciminib, when is approved according to a simple study, they compare asciminib versus bozatinib. Asciminib is working against T3, but bozatinib is not. So bozatinib is taken with food once a day. Unfortunately, I mean, the common side effect is the diarrhea with the bozatinib, and the optimal dose is 500, and I think most of us rarely reaching this dose, so we end up with 300 or 400 because of the diarrhea. Bonatinib is multi-target kinase inhibitors. Bonatinib has a unique, is unique because is overcome the resistance that coming from the T315. Bonatinib, again, one tablet is taken with or without the food, and I think the common side effect, the concerning side effect is mainly the cardiac toxicity or the vascular toxicity events and the blood pressure. That's why when we use it, we become more concerned regarding this, especially in the elderly and those with the cardiac toxicity. Asciminib is allosteric inhibitor, so is block the myristoyl bucket that I talk about in the first, at the early. It is taken as either once a day or twice a day, but the dose should be 80 in total. And again, you need to fast an hour before and 1 hour after. Regarding side effect, nausea, diarrhea, again, all manageable. Upper respiratory tract infection or symptom that look like upper respiratory infection, especially when at the early use, it's known to, it may disturb the lipid profile and also can cause hematological toxicity like other TKI. So this is the landmark study for the imatinib, dasatinib, and nulatinib, and all did show clearly there is significant major molecular response with these drugs. This is the base study for the bonatinib. I'm just going to show you the green column. You can see how significant bonatinib, how significant bonatinib can get the patient to the MR4 when you compare with the other, and here used after the first line. However, bonatinib, I think the side effect is the more concern, and the side effect mainly coming with the dose 45 milligram. So most of the approach we follow is we start 45, and when we get the BCR-ABL less than 0.1, we start tapering the dose down until 15 milligram, and you can see with the 15 milligram, the side effects is much less. Here is just showing you the dark blue is the percentage of the patient with the BCR-ABL less than 1, and the light blue is the incidence of the side effect. You can see when you go with the dose down, you start to have decrease those who have a good response. However, the side effect become much less. So before the asciminib era, so we have 5 TKI. Around 5 TKI, high rate of response, decrease the transformation to the acceleration of blast, nearly normal life expectancy with these drugs. And so why we still thinking about there is unmet need in the CML? So around 40% of the patient, they need to change the therapy at some point by 5 years. And only 60% they achieve MR4.5. And why this is important? Because I think TFR is a reality now, and we should discuss this with the patient. And only 50% who have sustained MR4 by 10 years. And approximately 50% with those patients in TFR, they will resume therapy. And don't ignore the vascular events with the TKI. I think it is significant factor. So here came the asciminib. So we have like 2 studies for asciminib. We have ASSEMBLE, approving asciminib as third line, and we have asked for first where they compare for the naive CML patient, either they take asciminib or comparing with the other TKI. And the primary endpoint was MMR4 at week 48, and the secondary point was major molecular response at week 96. So this is the result. So when you compare asciminib with all TKI, clearly It seems asciminib is the winner, and there is significant MR4 and MR4.5 when you compare with all TKI. But if you go to the second diagram, when you compare with, to the third one, when you compare with the second generation, yes, there is difference, but not that much. The clear difference is when you compare with the imatinib. Asciminib, it seems like how I understand the result. So I have now a drug that can give me the result as second generation TKI with the less side effect or toxicity. Here the toxicity, you can see when you look to the grade 3 or above is less in asciminib. When you look to the discontinuation rate, significantly much less with the asciminib. Regarding cardiac toxicity, is not zero in asciminib. So there is around like 2% chance to have cardiac toxicity when you compare with 2.9 in the second generation. However, imatinib, zero cardiac toxicity. So a clear safe drug. Do we have evidence for using asciminib as second line? Yes, we have just only a real world data, is an observational cohort study. They have around 500 patients divided to asciminib and second gen and other TKI. Most of the TKI was dasatinib, neratinib, and bozatinib. And they look to the side effect and the safety, and also they look the time to the BCR-ABL to be less than 0.1, which is the MR3, or BCR-ABL less than 0.01, which is the MR4. So here the result, you can see the discontinuation rate with asciminib is around 4.6 versus 10% in the other arm. Regarding progression to aplastic or acceleration phase is almost zero with asciminib. Here the median time to the MR3 and MR4 is around 30 months, the time to the MR3 versus 39 in the other TKI. And regarding the MR4, 59 versus 72 months. And they conclude that asciminib is a good, is higher rate of major molecular response as second line with less toxicity. So this is the NCCN guideline. So if you have a patient low risk, then you decide to use a TKI, you can see imatinib still there, and this is category 1. Second generation is a category 1 as well as the asciminib. So now you have 6 or 5 TKI, or you have a TKI, 1 asciminib. So how I should choose for the patient? What factor that's going to help me? So it is a big argument when you sit with the CML experts. So you need to have these data. You have to evaluate the disease, the face of the disease, the prognostic score of the disease, even the transcript type, which is, I think, most of the center they don't have. And what about the type of the TKI, the offside effect, and the strength and the mode of use? Like with the neratinib, you have to fast for 6 hours. Also the patient profile, age, comorbidity, lifestyle, the expectation, and your goal. What is your goal? Is your goal just to prevent transformation to the aplastic phase with good quality of life, or you are looking for a TFR? Also the drug availability and the resources you have. And just to remind you here, the CML patient, when you come to you, they already Google it, the CML. Is a blood cancer. When they read it's blood cancer, it's scary. They came most of the time panic. So you have those patients who come to you like well educated, questioning you, and I think this is the patient that you can looking for the best goal of therapy for him, because you are confident that he will realize the side effect, he will follow with you, and you have that patient in denial phase. He come to you. He just came because of the family, and you try to explain everything. You meet him first and second, and he's still in the denial. And you have those patients in between. He's compliant, but he's not asking a lot. He may be not noticing the side effect. So this is the journey of the TFR. So TFR is a reality in the standard practice. So for example, if you have a CML, like 100%, they will start a TKI. And then when you meet the criteria of the TFR, which is you need a TKI therapy for more than 3 years if you are using second generation, or 4 to 5 years if you are using the first generation. You have to know the BCR-ABL transcript. You need the patient to be in a deep molecular response for at least 2 years. And you have to make sure that he's able to follow with you monthly, and So if you meet the criteria, only 50% you will attempt in them, and who will have successful TFR is around 25%. This is the criteria of discontinuation. I just brought this slide to show you the amount of the restriction, the amount of the side effect that when you want to use the drug, you have to consider it. For example, those with the arterial events, nulatinib, bonatinib, it seems is not a good option. Severe hypertension, asciminib and bonatinib is known to cause hypertension. Those with the pulmonary hypertension, you have to avoid dasatinib, for example. And those with the pleural effusion, dasatinib, nulatinib also known to cause and so on. So what about looking for that tyrosine kinase domain mutation? Do we need to look for that at the diagnosis? According to the European guideline, no, it's not recommended either for chronic phase or even de novo blast phase. But those who's in treatment and we start to notice resistance, yes, is recommended. These mutations will not happen unless the patient is already in TKI. This is the incidence of the mutation, and the commonest one is the 315. This is just show you that if we have this data before, then you can't choose between these targeted therapy based on the mutation you have. Some of the mutation, they are resistance. So this is a good paper by Tim, and he looked to the probability of EMR or molecular response failure defined by more than 10% BCR-ABL at 3 months. And is dependent on the intensity of the kinase. So you can see the imatinib, the percentage of fail is around 34%. This is for the all CML patient. Compare with the 6 with bonatinib or 9 with the nulatinib. Based on the SOCR score, you can see those high risk is almost 60% if you use imatinib. To have a BCR-ABL more than 10% at 6 months, at 3 months, sorry. So you have to discuss with your patient. You have to decide about the goal, and you discuss with the patient. Am I just avoiding transformation and looking for the good quality of life and avoiding drug toxicity? I'm looking just for long-term control, or I'm looking for a TFR. So this table, I'm just trying to use like 3 factors, which is what is the priority for TFR, the risk score, and the comorbidity, which is mainly the cardiac toxicity. This table was made during a meeting with the CML expert from Europe and also from the Saudi Arabia. And we can just take an example, those with low priority for TFR, you have very elderly patient, frail, and he has cardiac toxicity, but the score was low. So we know those with the low score, they have a good response for imatinib. So here, imatinib came as first choice. Second, asciminib, and then dasatinib. So as we know, dasatinib doesn't have significant cardiac toxicity. When you look, if it is high score or high prognostic score, then you have to think about asciminib. Yes, there is kind of cardiac toxicity, but is much less than the second generation. And if you have high priority for TFR, then even the score was low and the cardiac toxicity is high, you need to think about asciminib. It seems there is no role for imatinib in such group of patient. Where asciminib monotherapy may not be the best choice is mainly for the very elderly, frail with the cardiac, with significant cardiac toxicity or comorbidity. Patient with a 6L1, and this is happening in around 7% of the CML. And it seems patient with a 6L, if you use asciminib, they will have more mutation of the ABL. And also the rare patient with a BCR-ABL transcript, which does not include ABL exon 2 or 13.3 or 14.3, which is only just 1% from the CML. Usually we don't have these data when you start to treat the patient. Just 2 slides, one about the conception and the fertility. So TKI therapy in general appear to affect some male hormone, at least temporary, but does not appear to have a significant effect on the male fertility. Miscarriage, fetal abnormality is very rare in the female partner of a male patient with CML. TKI therapy during pregnancy has been associated with both higher rate of miscarriage, fetal abnormality, a prolonged washout period usually need if the patient they're planning if a female patient planning to get pregnant, and any CML patient in general recommendation, you have trying to convince your patient to not to get pregnant until you get her in TFR if this is your goal. If that's not possible, at least for the first 2 years, to be in a good response. Regarding using interferon regarding using the, how we approach for those who's already got pregnant while on TKI. So usually you have to stop. If the patient in TKI, should be stopped immediately, the TKI. Usually you monitor them trying to be monthly. You have to involve your colleague from the obstetrician and the gynecology to monitoring the patient. And what option we have? We have alpha interferon. It's safe during the pregnancy. As we know, this is the initial drug used for the treatment of the CML. And you can use this temporary, trying to stabilize what you did already achieve with the TKI. At least the first trimester. So after trimester, if you're noticing the BCR-ABL is getting increased, then you can consider a TKI. What is the safest TKI? Nulatinib. It seems less chance to cross placenta. However, from the practice, we have a lot of patients who's got pregnant while she's imatinib, and they seem doing fine. So in summary, there is no single TKI is the best frontline choice for all CML patients. Imatinib, nulatinib, dasatinib, bozatinib, asciminib, all best choice in individual cases, is case by case. Current approved doses for second generation TKI may be higher than optimal for many patients. And I think good to have more new drug like asciminib, because clearly there is still unmet need for the CML patient, especially those younger in younger age. I think on time. This is the last slide, just to show you the CML. This is the CML in the early phase of diagnosis, and see the late chronic. Usually you have more evolution, more mutation, or even driver mutation. And thank you.
Thank you. Thank you, Dr. Ayel. As usual, you know, you are talking about the CML, which is a fascinating topic in hematology. So the common questions and in what we face in the practice, young female who is coming with CML and she is willing to get married. So what is your first
And
choice?
she's what?
She is willing to get married.
Yeah.
So what is your first TKI? Where you place asciminib in this regard?
So I have a scenario, just I'm going to mention the 39 years old female who came to me, newly diagnosed. She was panic and she was in a great stress at that time. She's not yet married. Then we start her on imatinib at that time, and just only 4 months she back to my clinic, and she gonna get married after a month. So she got a good news and bad news in just around 5 months. And then her sister came to me and mentioned clearly she's 39 and she's gonna get married and she's thinking about to get pregnant. I talked to her about the risk. I talked to her about the standard of care, which is she needs to be in contraceptive method for at least 2 years. We are trying to do our best. Like if she agreed for this plan, she will not get married for the 2 months. I will be more aggressive for this patient. I will never consider imatinib because I need a rapid molecular response. So I will go with the second generation. Given she's young, so probably she will tolerate the toxicity. So initially she agreed for this plan. We started in dasatinib. And then just after 6 months, she got pregnant. And her BCR-ABL is less than 10, is less than 1, I believe, but still is not an MR4. And she went to our colleague in the gynecology, and they told her clearly there is high risk for transformation. And just I want to remind you that the first slide I presented, which is the phases of the CML. So, I mean, we diagnose them incidentally. So if there is no treatment, they have up to 6 years before progressive acceleration case. Why I'm mentioning that, you have to understand the patient, what she wants, and because some patient, just for simple MBN, they get divorced because they start in hydroxyurea and they end up with, when they read about it, the chemotherapy, and she just, because of the toxicity, she get divorced. So yes, we are trying to follow the science, but we apply the patient on the science rather than apply the science on the patient. So anyway, she got pregnant. I stopped after 6 months, I stopped the dasatinib. I start interferon. We're lucky that we have the biggest at that time. And I maintain the BCR. It keep increasing, just reach around 5. Then I get her back strongly in the dasatinib. So to summary, think about stronger second generation lorlatinib to achieve a rapid major molecular response in such patient.
So just small question about the elderly. Are you going to follow the milestones, MMR, or just you will be liberal with the patient? Like if the molecular response less than 10, it will be okay for you?
Yeah, I mean, we have those patients, all of us, we have those patients with less than 10, but because they are elderly, frail, and you're looking here, your target here is avoiding transformation to the aplastic or acceleration. And I think we can achieve that with the less toxic drug. I wouldn't like pushing hardly to get them to the MR4 or MR 4.5.
Okay. I think with that, thank you, Dr. Ayel. So we'll move to